the background.
Go
Okay,
ahead.
so we're going to talk about anti-seizure medications that we use frequently in neurology. And you're welcome to join in the conversation. I think it's always useful to have interactive process rather than me just kind of talking about these medicines. There has been a remarkable increase in the number of medicines to fight against epilepsy and seizures. Let me ask you this, how many people have seizures in the United States, for example, or in the world, if you want to expand it? Anybody, any ideas, the
In the
numbers?
States, maybe 2 or 3 million.
Okay, what is the population of the United States? Any of you know?
Now I think it's for
325 million.
Exactly. So we usually say that maybe 1%, 1.5% or so have epilepsy. But I want to tell you that anyone may have a seizure. Any one of us in this room. I always explain this to the patient because I want my patients to understand that they're not strange or they're not very unusual. We all have the propensity and the possibility of having seizures. Unfortunately, many years ago, let's say 150 years ago or so, seizures were thought to be something from God or some kind of a devil. And it must have been awful for some patients who unfortunately had seizures, but it was thought that they were coming from outside, some kind of source, like a devil, for example. And many of these so-called Salem witch hunts, have you heard of that?
Yeah.
Yeah, many people were killed, they were burned because they were thought to be bad in some ways. Of course, we now recognize about epilepsy, but it's only been recently. When was the EEG invented, if you will, roughly? But 1939.
1926,
Very close.
1929, something like
Actually, 1939, very close. And who was the person who first demonstrated EEGs in animals, for example? Anybody know? Well, Hans Berger was a German neurophysiologist. And we're only talking about even less than 100 years ago. And when I started in neurology, Dr. Gibbs, and there's a picture of Dr. Gibbs on the wall. He was one of my mentors. He's the father of essentially modern electroencephalography. He worked with his wife in the laboratory. It was Gibbs and Gibbs. Many of the original papers were from Dr. Gibbs. He was a wonderful mentor. You can see him with me there. That big picture there, we're holding the journal. He was the editor of the journal EEG, and he started the association called AMIGA, American Medical EEG Society. I'm currently actually the president of the examination part of this, which is the Association of American Electroencephalographic and Neurophysiological Society. So the doctors, if they finish their training and they become internists or neurologists or neurosurgeons or anesthesiologists or physiatrists, they can take this exam. It's usually a 2-day exam. It's an oral and a written examination. Anyways, the main purpose of this talk, which is going to be very short, is to talk about anti-seizure medications. And I have a little note here, kind of a cheat sheet, which more or less lists all of our anti-epileptic agents. They have almost every year, there's a new one coming out. So we now have maybe 50 anti-epileptic seizures. It's unbelievable. There's no way that one doctor can really learn about each one of these. When I started, we only had about 3 or 4. And we knew about the medications, okay? They were like friends, they were like family members. We knew all the side effects of the anti-seizure medicines. We only had a few. Dilantin, have you heard of Dilantin? Phenytoin? So we had that, and we knew all about it. I did some research myself on it, looking at unbound and bound forms and so forth and so forth. We also had phenobarbital. Have you heard of phenobarbital, barbiturates? Okay. The very first seizures, anti-seizure medicines were bromides, because we then learned that you could get addicted to it, and there are all kinds of side effects to bromides. Same thing with phenobarbital. So Dilantin, and then after Dilantin, we had carbamazepine, or Tegretol, that came around 1965, 1970 here. And then after that, we've had a whole bunch of anti-seizure medicine. So one is called amino acid type. I'm going to give you the class, amino acid type. Can you give me the name of one anti-seizure medicine, amino acid type? Can you think of any? We use it all the time. Neurontin, gabapentin, gabapentin. So that's in the class called amino acid. And I don't use it a lot for seizures, but it was used for seizures. Nowadays, people use it to help them sleep, help pain management. It's now, in the last couple of years, it has been considered to be addicting, in the sense of patients come to the doctors just to get the gabapentin, not really to worry about their disease or illnesses. So you have to be very careful. Okay, you have to be careful. So that's gabapentin. I don't want to talk too much about it. The next group is the barbiturates, and we don't use barbiturates. Many of my older patients, they're so used to it, it helps them sleep. I don't mind writing it, you know, a little bit of the barbiturates. But let's say 30 years ago, it was very popular. It was a popular drug for the movie stars and people who wanted to get, you know, kind of high and fall asleep. Many people used it to commit suicide. So those are the barbiturates. The next one is the benzos, right? How many of you know the benzodiazepine anti-seizure medicine? Anybody? Give me an example of that. Yeah, clonazepam, right? Excellent medicine. I use it for anxiety. I don't use it as a routine drug for seizures, but it is an anti-seizure medicine. Clonopin, yes. Clorazepate. The medicine you mentioned we'll come to in a minute, but clorazepate is another one which is like that, kind of a benzo. Clorazepate, I haven't used a lot of it. The tranxene, actually a cardiologist friend of mine in California asked me about it. I don't use, you can see I don't use a lot of tranxene, but it is an anticonvulsant. It's a benzodiazepine. Next one is the hydantoids. We mentioned Dilantin. How many of you use Dilantin? Have you seen the doctors you deal with use Dilantin in India?
Yes, they do.
It's very inexpensive. And when I started, let's say 1980 or so, it was very popular, Hydantoids, and in the 1970s and 80s. And there were whole books written on all of the usefulness of Dilantin, like it made you a better person. I mean, I think I may have thrown it out. I have two books. It said that you, I don't know, you become smarter and you become nicer and you become, but people are using Dilantin for so many reasons. But we recognize that there are many side effects. So we've stayed away from Dilantin. I almost never give Dilantin. We have so many other. Another one is the succinimides. Anybody know any of the succinimides? Ethosuximide.
Yeah.
And when do we use ethosuximide?
Absence.
Absence, yeah. It's a nice medicine, but I only use it in patients with petit mal, absence. I don't think I use it in any other situation. Okay, then what about the Tegretol? What about Tegretol? We use other agents, Tegretol. Carbamazepine, we still use carbamazepine. It seems to be a good medicine. We use it in pain, trigeminal neuralgia. We use it in complex partial seizures. And you know, it's a good one. Carbitrol is a kind of a metabolite of it, and it's also used. And also another one that we had the other day is felbamate. Dr. Stein knows about felbamate. Excellent, excellent drug, but very powerful, right, Dr. Stein?
Absolutely. In fact, the PDR gives a statement, the patient has to sign before they use Felbitol. It's that dangerous in some cases.
The patient has to sign a waiver. The patient, because it can kill the patient. It's so powerful. On the other hand, it's a wonderful drug for very complicated seizure patients. Any of you know complicated seizure patients? What are those? Like when it's not just simple seizures or complex partial or generalized tonic-clonic. How about patients who have mixed, right? They may have atonic seizures, they may have drop attacks. Okay, sometimes seizures are very difficult to treat, and we use the conventional medications, but we end up using felbamate. And I've had a couple of patients with use of felbamate, but I get very scared when the white count falls or they become a little anemic, probably unrelated to the drugs, but you have to be very careful that you don't hurt the patients. So I frequently have got out of the felbamate area. We still use the carbamazepines. Okay, then there's some other agents. What about Lamotrigine? Anybody know Lamotrigine? When do we use Lamotrigine? Partial seizures, right? Sometimes even generalized, partial, primary, secondary, generalized tonic-clonic seizures, atypical, sometimes even absence, atypical absence, atonic and myoclonic seizures. What is that? What is the type of disease? They may ask you this on your exam, in which the person frequently has mental retardation. They may have other neurological problems, but they have uncontrolled seizures, intractable, we use the term intractable. They may have drop attacks. They may have tonic seizures, atonic seizures. Frequently, my patients have to wear a helmet. What is that called?
Lanox group,
Anybody know?
LGS,
Yeah, what is LGS?
Lanox Gold.
What is the G stands for Gaston, who was a famous French neurologist. Lennox was American, and then a French neurologist, Lennox-Gastaut syndrome. Have you heard of that?
Yeah,
You-
but I never see a patient with that.
Yeah, we have patients with that here. They're fairly rare nowadays. They used to be more common in the past. And the way you tell is they usually wear a helmet. I make them wear a helmet because they frequently fall and hit their head. Okay, but you will see some of my patients with that. And Lamotrigine is good. Lamotrigine. Let's see. Okay, Gabitril. Anybody heard of Gabitril? I have a few patients who are on Gabitril. They like it very much. One of my patients I've taken care of over 30 years. And she doesn't want to get off the Gabitril. It's also known as Diagon, right? It's good for partial and secondary seizure types. And that usually comes in 4 milligrams. It's kind of unusual. Now, Topamax is also an anticonvulsant, right? Topamax, topiramate, and also for partial and secondary seizures, you know about it. How about Depakote? Any of valproic acid? Anybody know? Have you had experience with it?
Yeah.
Valproic acid, okay. Partial seizures, secondary. And then, of course, we have the Valiums, the diazepam, which is an anticonvulsant. We now have Valium that you can give rectally. Like if you're a mother and your baby is having seizures and you can't stop it and so forth, rectally and also nasally. So we have intranasal Valium we have as well. Rectal diazepam, it comes in a gel. It's known as Diastat. And then we have various lorazepam, which can be given as an injection. Like in a patient who comes to the emergency room in status epilepticus or seizures, right? Lorazepam is a good, like a benzodiazepine immediately. Short acting relatively, so you have to cover it with other anticonvulsants. And valproic acid now can be injected as well. Have you studied the mechanism of action? You want to spend just a minute to the mechanism of action of some of these medicines? Like, for example, the Valium, the diazepam, how do they work?
Receptors.
Yeah, okay. What about Lamictal? Lamotrigine, anybody? Lamotrigine.
That's on sodium channels.
Which one?
I don't know which one, but it.
Lamotrigine, we covered Lamotrigine, how does that work? Why does Lamotrigine, why is it an anti-seizure medicine?
Doesn't have multiple mechanisms. Major one is sodium channel blocker.
Um, what do we know about it in terms of maintenance and pediatric and elimination half-life? The problem with Lamotrigine from a clinical use is that it takes a few days to work. We don't have an intravenous form. And so it may take a week or so and you have to go slow. What is the bad side effect of Lamotrigine?
Stephen Johnson,
Yes.
skin rash.
yes. They may ask you that on the exam.
They did.
Is that right? They
They
did?
did.
Interesting. What other questions did they ask you on the exam?
This was like one of the most like important question. It kept coming up.
It kept coming up, isn't it? Yeah. And you know, I have to tell you that we have about 500 patients with seizures. We're always worried about it, but I'm never really fortunate. I've never had a problem with Stephen Johnson or anything like that. But sometimes they do have a rash, and we say, well, let's get off the medicine. You know, I think we're overreacting to it. What's your favorite anticonvulsant? Anybody?
Levetiracetam.
Which one?
Levetiracetam.
Okay.
Levetiracetam.
Why is that? Keppra.
Yeah, copper. Just
Why is that?
less side effect.
Better tolerance and less side effects compared to the.
What are
other
the side effects of Keppra that you have to worry about? You have to tell the patient.
Mood disturbance.
Yeah, mood disorder. They may ask you that on an exam.
Mhm.
Levetiracetam was not around when I started.
Mhm.
Probably not around when Dr. Stein was working, but it's the most popular anticonvulsant. Every young doctor, like the five of you, every young doctor is using Keppra, right?
Yes.
And that's because of the advertisement, really. There's no other good reason. Just that in America, it's been so popular and so popular in the emergency room. They actually, whoever sat down with the advertisement was brilliant, was a genius. Because there were like 3 or 4 other anticonvulsants at the same time. None of them, like for example, Barbiturates, none of them have become this popular.
Mhm.
It was a genius. The advertise. One day there'll be articles on how Keppra was pushed. All of our emergency rooms, all the detail people coming almost every week to push the Keppra. And of course, now that levetiracetam is off, You don't see anybody pushing it, promoting it, etc. But it made a tremendous memory in people's minds. So I don't know whether it's good or bad. Is it good or bad? That advertisement and marketing is the key to any pharmaceutical agents, the marketing.
It is. It isn't.
Do you think it's good?
It's good.
It's good. Okay. What about you, Andrew?
I think as long as there is solid evidence base,
Yeah.
I think that won't be a problem for me. Yeah.
Okay. Anybody else? Any other views? Anybody with strong views? Not really. Yeah. Well, what's the bottom line? Okay, the takeaway. We have probably 38 to 40 anticonvulsants. We probably don't need that. I mean, really, we don't need so many anticonvulsants. But they all seem to work. So the bottom line is, the takeaway is, when you have somebody with a seizure, generalized tonic epilepsy, so you try one medicine, your favorite, Keppra, let's say. There's a over 50% chance that it's going to work, maybe 60%, right? So then let's say that person has another seizure. And then you pick a second, like Lamictal, for example. What are the chances that the Lamictal will work, whereas the Keppra didn't work? What are the chances adding Lamictal to Keppra? I want to make a point here. What is the chances?
You mean the chance?
There's a 60% chance that the first drug is going to work for the
Oh, you
seizure.
mean right?
The second anticonvulsant, what are the chances that that will work together with the first one? It's only about
10%.
10%, 14%, okay? So that gives you about 75%, right? And let's say the person still has a seizure, right? You have Keppra and Lamictal. Now you want to add, let's say, Gabitril. What are the chances that the Gabitril is going to work? How much?
Less than 10, like about 5%.
It's
Not
less than
significant.
even 5%. It's 4%, 3%.
Mm.
And I can go on. A fourth pill will be like 1%.
Mm.
On the other hand, the other side of the story is that all these drugs are interacting and they have side effects, untoward effects, cost, et cetera, et cetera, et cetera. So what is the lesson here? What is the takeaway?
It would be like the drug has to be chosen according to the side effect profile and the patient.
That's important,
And they
right?
all have similar efficacy,
Right.
so it has to be patient specific.
But one more point. The other point is that if you tried one pill, big chance that it's going to work. If you add a second one, going beyond the second one, it really doesn't make much sense. You're risking side effects, you're risking untoward effects, you're risking interactions, your allergy, et cetera, et cetera, et cetera, for a very little return, right?
Mhm.
And that took a while for us to understand. The thinking was, well, you add one and then you add a second one and then you add a third one and a fourth. And sometimes I see patients who are on 5, 6 anticonvulsants. And I know that's not good for them.
Yeah.
So I frequently try to taper one or the other. All right, I'm not gonna take any more. We'll have further talks. You know, I just wanted to kind of introduce a few concepts to you. I think this rotation, we want to emphasize an approach to patients rather than just data points. Because the science and the data points, the half-life, the elimination half-life, the interaction, et cetera, you can look that up. But what you can't look up very well is the approach to the patient. And kind of like big thoughts, large thoughts. And that's, I think, Dr. Stein, do you agree with me? That's really what we want to train you.
Absolutely. Yep.
Rather than individual points, which you can look up yourself. Now you have the cell phone and so forth, you can look it up immediately. We're in a library here, and I think the only reason we have the library is to make it look good or something, because no one ever looks at any of the books, Dr. Stein. Can you see the library?
Yeah, that's not true. Some of the books you can't find. Hewling Jackson's writings you can't find. Gower's writings, you can't download these things.
I have
You need that.
historical books.
Yeah.
I have historical books, that's true. And we have some kind of classic first edition books, but the truth is, I used to change the books every year, and there were very new ones up to date in internal medicine, all of the textbooks on internal medicine. You can see the heart, the skin, the nephrology, etc. So we have all of the textbooks on internal medicine. Over here is toxicology on the right-hand side. These are books on toxicology, neurotoxicology. We have a big interest in that. Behind me, to my right, behind me here is pediatrics, neurology, pediatric neurology, okay? And to the left is general neurology, adult neurology. You're welcome to use the library. Each one of our centers, we have a library. We have books in every office, we have books. I'm a big bibliophile. I personally at home, I have about 8,000 books, but those are not medical. I do have some few medical, but they're non-medical generally. Many years ago, when I was a little boy, libraries were important places to go. Probably not today. It's kind of like died with the dodo bird. I actually have a dodo bird in the Potomac Center. I have it there just to remind me. No, life changes, Dr. Stein, and we have to change with life. Don't you agree?
Yeah.
Because you've done rotations elsewhere, and I don't know how the other doctors deal. Do they have like old libraries and stuff like? No, probably not. Right? And it doesn't, like when you see a book, you get excited, you want to touch it, you want to look. No,
I was just looking at.
you were looking at the names.
Names, and then I saw peripherally.
You know, I have to tell you, when I was doing externship in London, for example, at a famous place called Queen Square, London University, and they had a library, and I would spend hours in the library, and I would photocopy. I was crazy. I think back now, I would photocopy all these articles and then bring them back home, luggage full of articles. And the question is, why did I do that? You know, and here we are. None of you are running to books or, oh my God, he's got a book on the heart. Let me look at it. Eugene Braunwald, you know, these are like famous names and so, right? It's not important.
No, it's definitely important. Yeah.
Really?
No,
You
the
still-
books are important. Yes, of course.
You still,
Yeah.
I have 3 sons and none of them are interested in my books. So I've almost about 8,000 books and I don't know who's going to do what. I think they're just going to throw it out. Dr. Stein, what are you going to do with my books? When I kick the bucket, what are you going to do with my books?
My wife says the same thing about my books. My kids
You know-
don't want them.
My kids don't want my books. And you almost have to have a large house, a home, big home to take care of all my books. I have books in every room, every floor. But I'm wondering what people really think. They see it as a liability. They don't see it. I don't know. I just love books. You know, I have books. I look at it. You don't have to read a book from cover to cover, but you can read, like, get an idea. It makes you feel better. I don't know what to say. None of you read books anymore. You do?
Yeah.
You do?
Yes.
Okay. All right. Maybe there's hope. Dr. Stein, there may be hope.
Okay. Okay.
Anyway,
Thank you.
books are wonderful. Thank you. We have a patient waiting. First patient has headaches. We have a patient with headaches, a brand new patient, migraine. Then we have a patient with a head injury coming up. And then we have another patient who's Russian coming in with carotid CT lab results. And then we have somebody, sharp pain behind the eyes and dizziness when going from sitting to standing. And then we have somebody who's returning after 3 years. We see a lot of military, and we see a lot of people here who are coming back from overseas, you know, because we're right next to the Foreign Service area and White House down the street. And we have attention deficit disorder as well. Anyways, we have some interesting people coming in today. I think we may have some lunch today. If we don't, there are 100 restaurants down the street because all of the GW, George Washington University students live here and they go to school here. So this is part of the GW campus, the GW campus. So if you want to kind of go downstairs, you go out of the building, you can turn to the right and just follow the students. You can turn to the left. There are restaurants going down to the left, but also a lot going to the right. Okay, you're welcome to go and take a walk. We have a garden next door with a beautiful garden. There's a French restaurant next door as well, but there's places for like sandwiches and stuff.
Yeah, sure,
Okay.
sure.
Do you have any questions? Okay, so let me get the first patient then.